Good morning. Boy, I have never seen a more exciting class. If our medical students could be one half as enthusiastic as you, we, the faculty, would actually come and enjoy teaching. So, close your books, take out your pen or pencil. It's time for our weekly Limerick Challenge quiz. I heard some up there. Was that disapproval, or you didn't study? All right. This is a hard one and a long one. It gets progressively more difficult as we test your recall of the previous week's lecture. So, we're going to start with the first one. The arthritides cause one to shout. They cause pain when you try to work out. With a high uric acid, joints get painful from placid. And a steak and red wine give you... Whoa! I didn't tell you the prize. We're sort of working on the prize. The prize, we decided that the prize will be the last banana that's in the... Rheumatoid and OA, each a kind of arthritis in old age you find. Rheumatoid joints in flames, OA's seen more in dames. Loss of cartilage makes joints creak and... Excellent. Okay. You guys are doing well. When your knees feel like meat that's been ground, since you've gone from being svelte to quite round. If it's weight loss you choose, cut back calories to lose 3,500 calories per... Whoa. Gosh, I am impressed. I am impressed. We may have a scramble for that last banana. Embryonic stem cells can be grown to become any organ we've shown. They've a source controversial, so low prospects commercial. Mesenchymal stem cells come from bone. Excellent. Okay, I heard there was a little more hesitation there, but the answer came out. From last week, I sure hope you did glean that in Parkinson's tremors are seen, with poor balance, unstable, getting round much less able. There's a deficit of... Right. You guys are awesome. Of longevity, there's a compression. A full third will develop depression. In the Parkinson's state, there's a shuffling gait. Hypomimia, low facial... You even remembered that. I tried that on one of my geriatric colleagues, and he was stymied. What the heck is hypomimia? You know. So I'm impressed. So now we can get to the meat and potatoes of the first lecture, and I'd like to introduce Dr. Angelo de Mattos. Dr. de Mattos is Associate Professor of Medicine and Chief of Transplant Nephrology at UC Davis Medical Center. And I am not going to tell you the country of origin of his charming accent, but I will tell you that this country of origin has the largest concentration of people who speak that language. Hint, it's not Chinese. And if you're planning to go to the 31st Summer Olympics in 2016, he can probably tell you all the really cool, out-of-the-way places to visit in that location. Wrong. Any guesses? You know, when the average IQ is you know, bordering on 200, you can't fool this audience. I'm impressed. Dr. de Mattos, it's a pleasure. Thank you. Thank you very much.
Thank you all for being here on a Saturday morning, especially on a holiday weekend. I will probably trap it here because of the microphone doesn't walk it. So, but I usually may have some sort of attention deficit disorder. I have to keep moving to be focused. I should warn you, there will be blood. I will show a couple of pictures with blood. So I will warn you if you cover your eyes, and it will be something even better than blood at the end. So this will work. So I will warn you. Dr. Hirsch asked me to talk a little bit about transplantation for the older recipients, and it is a very pertinent topic, and I will try to show you why is that so. When you get to be on this line of work for more than 25 years, as I have been, we have seen a lot of changes over that period of time, to a point that, we would consider age per se a contraindication for such procedure, and now it's actually as I will show you, it's the population that grows, the segment of the population that's grows faster. We do like to collaborate more with Dr. Hirsch, because we are at loss on the healthcare of those patients. So without much delay, see if I can go forward. I said this one will go forward. Yes. So I would like to talk a little bit, I won't doing too much on this thing, on the impact of age in renal function. Then I'll go a little bit to survival with transplantation as compared to the other modality of therapy for kidney failure, which is dialysis. I will tell you a little bit about the donor gap. What is this donor gap thing? It's not just donation for the mini medical school. There's another donation that we lack there. And I will talk a little bit about the utilization and outcomes for non-traditional kidney donors. And that is the juice of what we do. And we are very proud to have this program at UC Davis that it's a leading one in the nation. And then I will talk a little bit about the future, yet I'm always cautious about predicting the future. I think it's we have been around a couple of times, and we have seen things, this will be the next thing, and then that 15 years later hasn't realized. So I will tell a little bit what I foresee being a major development that for the next decade or so. So, is that working? Hello? Yeah. So this is a graph that, again, I have to show graph about renal function. And all the nephrologists like to show this glomerular filtration rate, where that is how we measure renal function. And that is just to say it's an old paper, actually it's a new paper from Brazil, so that's what I brought it here. But that's just one of plenty, hundreds of papers have shown that as we age, we lose hair, we lose muscle, we lose kidney function. And that's true. Bar some debates about if this is physiologic or pathologic, I think what is truly pathologic, I think it pertains to the slope of the decline of renal function. So we all lose, on average, about 1 ml per minute of renal function, glomerular filtration rate, when we age over the age of 40, which is pretty young as far as I'm concerned. So, so if you pretend that 100% of renal function when you reach age 40, you lose 1 ml per year, so 1% per year. So by age 70, you should be about 70% renal function. And that's pretty much what happened across gender, across ethnicities, across geography. So we all lose renal function. And I will mention that because the type of kidney donors that we have nowadays, I shouldn't say the good old times, but when I started doing this in 1991, in Oregon, most of our donors, and that's probably true in the country, were the 25, 35 years old kid that had a motor vehicle accident, a motorcycle accident without a helmet, and that's what were typical donors. Our typical donors nowadays are the 67 years old with a stroke. So, deceased donor, I'm saying. So we have to take that in account. The renal function goes down with age, so those kidneys will come with a little bit of deficit of function to start with. So Why don't everybody end up on dialysis at the end of their life? Well, because this Mother Nature is very wise, and we also slow down the metabolism and we lose muscle mass. So in reality, we do not need as much renal function as we age. And that is important because, again, I will mention the group that goes the faster on the waiting list are the elderly. And again, what we're trying to do is to match their demands to the supply of organs. So I will mention about that too. So, but it's true. We lose muscle mass, we lose hair, we lose kidney as we age. So, and that is what I'm saying. This is the most recent national data, registered data that showed I don't know if the little light we show there, but basically showing that the group that goes the faster, look at the lower panel here, in terms of people achieving end-stage renal disease, this is ESRD that say there, is the group above the age 65 to 74 or 75 plus. So there is a demand for services for end-stage renal disease, particularly in that age population in this country. And that's true for most of the developed countries. And I just showed this thing because just want to mention that we are in a particular area of the country in our state that's, the Central Valley, California. I'm sorry, I tried to put a slide here. It probably doesn't show. But that's what you say. The Central Valley of California has a huge incidence, more so than other areas of the country, in other areas of California, of patients with end-stage renal disease. So it is a local problem that we need to address. We are the main transplant center that serves the Central Valley of California. The other programs in Northern California are in the Bay Area, and there's nothing between us and LA. So we do serve that area. So how do we treat renal failure? You can put patients on dialysis or you can transplant them. That is just, again, from showing that for the younger population, the modality that's applied more often is transplantation. And then as the age group goes up, we see more dialysis and less transplant. And I will show this again, a little bit of an older slide, and I will show what the trend has been currently. But that's true. We actually tend to offer more dialysis than transplant for the higher age group. And why we do that? Why do we offer transplants? Well, transplant has been shown to improve survival. Lifespan is increased with transplantation as compared to staying on dialysis. And that's a little bit of difficult graph to read. But then if you artificially keep the mortality risk for people on dialysis, one is steady. So that's just pretending that that's what you have over the years. And you compare with transplantation, which is the solid line, we do see a higher risk of mortality in the first 90 days, 106 days, because of surgery. Transplant is a big surgery. It put people in, plus the wonderful poisons that we give to people to immunosuppress them so they won't reject the kidney. We pay a price for that in terms of rejection, in terms of infections. So there is a higher mortality risk in the first 100 days or so. But then beyond that, there is a big survival benefit. So it equals the survival by 240, 250 days. So from their point one, it's gains. So people actually live longer. And I will show that, I may have a slide there that shows that they probably live better with a transplant as compared to dialysis. So, and that's true across age ranges too. So if you have a 19 years old kid that you tell them today, oh, you're going to start dialysis today, as compared to 19 years old kid, and I said, okay, instead of starting dialysis, we'll give you a deceased donor kidney, a dying donor kidney, which is, again, not the ideal one, but it's what we have the most in this country. So actually, just by doing this, we are increasing their lifespan for more than 1 decade. And as we age, we also, we continue to see the survival benefit, but again, life expectancy goes down as we age, obviously. So, but it's still present. Even if you transplant patients over the age 75, 80, there is still some survival advantage. It's not measured by decades, it's probably measured by years or so. But there is a survival benefit also with transplantation, even in for the senior citizens. So, and that is true, and that has been shown, again, it's slide from 1999, and you show that since then, the proportion of patients on the waiting list has increased dramatically over the past 10 years or so. So actually, the only group that has grown during this period of time are people over the age of 50. That is because of the survival benefits and the improvement in transplantation that we have in this country, and actually worldwide. Donor gap. So what is donor gap? So if transplantation is so good, why don't we give it to everybody? Well, we cannot, currently we cannot give it to everybody because we don't have enough organs. That is the limiting factor for transplantation currently. We do not have enough deceased donors, or live donors for that matter. So this is the waiting list on the red line on the top that we keep going up and up and up, and there's about almost 56 or 57,000 people waiting for a kidney only in this country at the end of 2012, and every year we do the most 16,000, 15,000 transplants. This is adding up the living donors and the dying donors or deceased donors. So there is a big donor gap, and it's true also for patients, for candidates over the age 65. So there is we don't have enough organs to give to everybody. That pushes us to think outside the box. So where can we get those organs and how can we meet the specific needs from the people older than age 60? We do have to find alternative type of organs, and that will be the next part of the talk. So this is the proportion of the elderly candidates in our waiting list. Again, over the past 10 years or so, we came up from 5% to 15-20% of our list is actually composed from people, and actually this is age 65. We are seeing, like the rest of the country, an increase of this of that population in our waiting list. We hate talking bad things about California, but that is a bad thing about California. We have one of the longest waiting time for a kidney transplant in this country. And there's several potential explanations for that. I will not go into that. But again, I used to work in Oregon. That was far better situation that is and it's, again, I will just skip that. I will not go too much on my rant. Deceased donations is also not the best place to be if you're waiting for a kidney transplant. So it could be worse, but it could be much better just in our neighbors to the north. But again, we don't have that many donations, and people wait longer and longer and longer here in California for a kidney. That said, if you look at, again, the rate of transplantation according to age, like the waiting list, also the transplantation rate has increased. This is the first slide there on the left side, show that people for recipients age 50 to 64 or 65 plus is the group of patients that have received more transplant over the last decade or so. So I just tried to make the case that this is a real problem, and we are seeing that population, a huge demand for transplant on that population, and we have to struggle to match the demand for those transplants with the limited supply of organs that we have. This is again the proportion of elderly patients, 65 or older, that we have transplanted at UC Davis. Had spiked a couple of years, 2007, and kind of leveling off a little bit, 15%. Or so in 2013. So we should do better. We could do better than that. Again, there's plenty of alarming papers in the literature. If you read it, this is a recent one that, again, it's I guess it plays on the fears of people, say that if you are 60 years old nationwide, if you're listed, you are more likely to die on a waiting list to get a kidney transplant. So, which is partially true, but it's more to that truth that meet the eyes. So how do we address that? We have more people waiting for transplant, and we don't have enough organs. So, well, in 1997, the smart people paused and looked and said, listen, and I remember that in Oregon, if you are 55 years old and then something happened to you and you and your family manifest, oh, when I pass, I want to donate my organs. People in Oregon and across the country said, oh, 55 years old, it's too old. We don't want their kidney. So we would not use those kidneys way back then. Then people came back and said, well, that doesn't make any sense. If you are 60 years old and you want to donate a kidney to your son, daughter, or your grandson, we'll take your kidney. How come we don't take kidney for people that are dying at 55 years of age? It doesn't make any sense. So they convinced some smart people, ethicists and doctors, and they say, well, what is the risk that society will take without backlashing against transplantation? So they said, well, we'll probably take kidneys from older donors, provided that we can estimate it, that the projected survival, rate of failure is about 50%. So if you accept an increased rate of late by 50%, and we think that society will take that, we'll take those kidneys. So based on that conference in 1997, they come up with this expanded criteria donor organ policy that was enacted, actually, believe it or not, October 31st, Halloween, 2002. I don't know if they picked the date for that or not. So basically, they now have a national policy to distribute organs from dying donors, deceased donors over the age of 60, or between the age 50 or 59, if they have at least history of high blood pressure, die of a stroke. So not what they call standard criteria organ, not low-risk organs. So with the understanding that those kidneys will have some damage coming in, so who do we offer those kidneys? We offer those kidneys for people that do not need as much kidney function. So again, we will not give a kidney from a 67 years old donor, again, because I mentioned the renal function comes down, to a 20 years old kid that has a lot of muscle and metabolism is spiking. So, and then they left after to the centers who did they offer those kidneys to, and with the idea that we should offer those kidneys for people that the life expectancy on dialysis will be shorter than the waiting time on the waiting list. So it makes sense that if they're going to die on dialysis, it's better to transplant them and prolong their life. So we give priority to them. So now at UC Davis, we offer those kidneys for people that are over the age 55, my age, so very young people. So we offer those kidneys for people older than age 55. And if you, long behold, if you look at it, 8 years down on this policy, 25% of the deceased donor transplant that we do in this country come from this type of donor. Again, population gets older, plus I truly believe that seatbelt laws, helmet laws work. So we don't have that many young people becoming deceased donors, which is good for society, bad for us, but it's good for society. So we do 25%, one of each 4 kidneys that we put in nowadays come from expanded criteria donor. So again, we show that survival is better with transplant across ages. So what about with those kidneys? It's also true. It just takes a little bit longer because again, it takes about, it takes about 226 days as compared to 106 days from younger kidneys. But beyond that, it does favor transplant, even with those ECD kidneys as compared to staying on dialysis. So again, that is considering death of the recipient as a graft failure. So it's actually, this is considering that we put in those kidneys to people older than age 55. In our case, some centers go up to 60 years of age. So there is a survival benefit even with those expanded criteria donor kidneys. Again, at UC Davis, this is a little bit of an older slide, so that is our own data. We look at for this 5 years, 4 years, and during that period of time, we have done 344 standard criteria donors younger than 50, and we've done our share about 25%, close to 25% of ECD kidney. And you can see that at 5 years, the kidney survival, this is kidney survival, not patient survival, it's about 76%, which is pretty good comparing that, considering that mortality on dialysis for the same age, it's about 50% in 3 years. So that is pretty, a great development. So, but they are not all the same, are they? So we talk about the people lose kidney function as we age. Can we actually select the best kidneys to put in? So, and people have shown that. So if you biopsy the kidney before we put it in, so you can have people like the top row there, the 3 pictures, and I would say blue is bad, red is good, or pink is good on this picture. So if you see it, the top one, there's a lot of blue, a lot of red, few blue. So that means that the blue is scar tissue. So that is a good kidney. We can put it in despite being from a ECD donor. So the second line is kind of borderline. We will try. It's a high-risk kidney, but we'll try. And the one on the bottom is too much blue. We won't do it. So again, we don't want to put people to a big surgery that's transplant if you don't have expectation that the kidney will work. So we will discard this kidney and we will use the other 2 on the top. And that's what is shown in this data that, the red curve there on the top says the probability of people going back on dialysis. So if you do a single kidney, if you just take kidneys from ECD donors and do it without biopsy, the probability that you go back on dialysis is much higher than actually if you biopsy the kidney. Again, this is a selection bias. We are biopsying, we are not using kidney that have a lot of scar tissue, so we actually put the good kidneys. So that is what we do at UC Davis. We biopsy all ECD kidneys. And the other thing that I mentioned here, it's missing on that slide. What if we biopsy the kidney? The kidney is on the high-risk population. It's not to a point that we will not use it, discard it. But it's something that we are not sure if we should put it in one kidney because it probably won't give it enough function for the patient. So what do? We put 2 kidneys. So instead of discarding those 2 kidneys, we lump their function together and offer 2 kidneys to the same patient. And that is what is shown there on the picture there. And here's what they call a renal scan. So we give them a radial tracer and see if the kidneys grab the tracer and they pee, and that is pee come down at the line. So we do that, and we have done that, and that's I think that's the survival. The kidney survival for dual ECD on the top, and it's kind of, we haven't done that many at that time. Now we have done almost 40. So the survival of the kidney is as good as a standard criteria donor. Again, we are doing 2 kidneys instead of 1. And it's definitely better than a single ECD kidney. So why do we do that with all ECD kidneys? Because if we can use 2 kidneys, we can benefit 2 patients. So that's why we also have to take that in consideration. So, but instead of discarding the kidney, we'll use 2 of them. So, blood, sorry, we will be blood now. So let's march to the other end of the spectrum. What if we use very small kidneys? Those are what people call baby kidneys. Well, if tragedy happens, baby is dying for whatever reason, the family wants to make the gift of life. They want to donate the liver, they want to donate the kidneys, and if you look at that for babies under the age of 5, under the weight of 5 kilos, 80% of those kidneys are not even procured. So most of the centers said, oh, we won't touch it. We don't want those kidneys. Why is that? Because they are very tiny. The vessels are very tiny. There's a higher risk of thrombosis, the kidney clotting, and the function is small. It's slow. So, so most of centers will not even procure. 80% of the kidneys were not even, despite the family saying, oh yeah, we want to donate the kidneys. And then when they are procured, 80% of those 20% they are procured are not used. They go to waste because nobody will take those. So Dr. Perez and his group here, our transplant surgeon, had developed some techniques to actually allow us to put even those small kidneys, and that's what his fingers are. They're tiny little ones. They're about an inch and a half each kidney. And the vessels, instead of transplanting the little renal arteries, they use the aorta of the baby and the vena cava of the baby because they're bigger vessels. So they transplant those, what they call en bloc. The whole thing comes together. And that's what's showing up there. So you suture the aorta of the baby and the vena cava of the baby to the regular place that we do a kidney transplant. So we can use those kidneys. The good news are, that's our outcome. So we have 95%. This was a little bit old slide in 2011. We have done actually more than 200 of those kidneys, and we get those kidneys from everywhere, including Canada and Puerto Rico. So they send kidneys to us because they wouldn't use there, and we would use it in UC Davis. So we've done more than 200 of those kidneys. And again, we select people with lower metabolic demand because the kidneys are small. We wouldn't put those kidneys on a 20 years old, 200 kilo recipients, but we would use it on a 65 years old, 55 kilos recipient. So, because again, they will match the metabolic demand. So the results are pretty good. Actually, they're better than standard criteria donor. I mean, the caveat is obviously we offer standard criteria donor to everybody, so we will offer to the 20 years old. So the bonus of this thing is, which is fascinating, actually fascinates me, and those kidneys grow. They grow over time. So if you do an ultrasound on them 6 months, 8 months out after transplant, you end up with 2 adult-sized kidneys. So this is just in 2 months. The kidney have grown 2 centimeters. They come from 7 centimeters to 9 centimeters. So those kidneys grow. So actually, I'm amazed to see those recipients a year later, they have a creatinine that's actually better than mine. They have a better renal function than I do. So this is a good deal. Again, we try to match it at the beginning with the people with low metabolic demand. So, but that is used. I think it's otherwise those kidneys will be discarded, and we show that actually we have an outstanding survival above 90%. And 92% in 1 year. So what else do we do to not let kidneys go to waste? Well, when people die, they want to donate the kidney. The surgeons go there, take the kidney, flush it with cold solution, put in a bucket with ice, and ship it around the country, bump it up and down. So we call the patients, the kidney is on the ice for 12 hours because they came from Miami or so. The kidney suffers with that. So what we do at UC Davis for all the ECDs and all en bloc kidneys, all the pediatric kidneys, we put that on this perfusion pump. Basically, it's we hook up the artery of the kidney or the aorta in case of the baby kidneys to this perfusion pump, and then we flush it with cold solution for 6 hours, 8 hours. And actually they have the little knob there that we crank it up, the flow, so increase the velocity of the pump, and then we measure the resistance, how difficult it is for the fluid to go through the kidney. So again, if there's a lot of resistance, if you crank up the volume and there's a lot of resistance, then, well, maybe we shouldn't use this kidney. There's a lot of vascular disease, there's some resistance, so we discard those kidneys. So, and I always used to say to my patients, by doing the biopsy and putting the kidney on the pump, we are actually taking a look under the hood, and we are actually taking for a test drive. So, and that's what we do at UC Davis, and we are the only center here in Northern California that pumps kidney. Nobody else here pumps kidney. The centers in the Bay Area don't do it. And why they don't do it? Because it's more expensive. So each kidney that we put on the pump, it adds to the cost of $1,200 per kidney. But again, if we don't do it, we wouldn't be transplanting those kidneys. So I think it's well spent money on those. But we do put the kidneys on the pump, and sometimes we discard kidneys based on the numbers of the pump. And then is actually, that's not our data, and we present that in a national meeting a couple of years ago. So if you get an ECD kidney and you put it on the pump, their survival, the kidney survival is much better than if you don't put the kidney on the pump. Do I think that the pump helps the kidney per se? I'm not sure. Dr. Perez thinks so. I'm not sure if we can say that. What I think it can say that actually is a selection bias. You select the good kidneys. If the kidney doesn't pump well, you won't transplant it. But if you never pump the kidney, you will never know if the kidney would be good or not. So I think it is a selection. But again, if it is a tool that allow you to select better kidneys, all power to Dr. Perez to put those kidneys on the pump. So yeah, it makes a big difference for ECD kidneys. Maybe that's why we use so many ECDs at UC Davis. And actually, if you pump a ECD kidney, at least back in 2008, we showed that survival of the kidney is very close. It's comparable to a kidney from a young donor. So again, you are selecting the best kidneys to put it in. And I think that is pretty much I have at this point. So again, I hope that we convey the idea that chronic kidney disease prevalence increases as we age, and plus, I failed to show that it's as life expectancy increases in this country and around the world, we'll see more patients that live long enough to have kidney failure. That's another impact of increasing. That is one of the side effects of good primary care. So now the primary care doctors are keeping the patients long enough so they can see me and see Dr. Hirsch. 20 years ago, 30 years ago, that wasn't the case. So I think I also showed that transplantation is the preferred modality of therapy for treatment of end-stage renal disease, even on the elderly. Why don't we do more? Because the organ shortage, we do not have enough organs to give it to everybody. So we have to do what we have it, and we have to push the envelope, try new donors, as we mentioned. That has been done in a national way, national scenario, and we have done locally with the pediatric en bloc kidneys. And again, we try to match the metabolic demand to the kidney mass that we transplanted. Again, doesn't do any good to people put kidneys, they won't last them a decent amount of time, 3, 5, 7 years. So I think the elderly is well positioned in terms of a population that will actually benefit from, because if you're going to wait for a standard criteria, young kidney, you're going to wait for a long time, especially in California. So I think we do have to make an effort to match the supply and demand. Being around the corner, as long as I have it, I do have a word of caution. With age comes a lot of syndrome, a lot of things that can be adversely impacted by us doing a big surgery and giving the medication that we give it to people. So a patient selection is key. I always get confronted with this. Oh, what is your age limit? We don't have age limit. We transplant people age 81, 82, 83, but they do have to be physically fit to do so. Otherwise, we are inviting problems. So we look forward to collaborate more with Dr. Hirsch. His group has a very good handle on who would actually perform physically, mentally, socially better with transplantation as well as compared to, again, we don't want to do harm to people. We don't want to do transplant just to show that we can do transplant and people have a horrible outcome. That is not the idea. But we want to try to figure out, as to the best of our knowledge, is not perfect, who would actually benefit from a transplant, who actually will be better off left on dialysis. We actually may do worse if we try to transplant them. That said, chronic kidney disease is a major player in progression of frailty on elderly patients. So now we are facing with this dilemma. Well, they have chronic kidney disease. Would transplantation bring the renal function better? Would that be beneficial as compared to, or do we have a point of no return? Can we figure out we can push the limit up to this point. Beyond that, it probably is not a good idea to do it. We don't know. And that's what we will look forward to working with Dr. Hirsch to try to figure out which population will benefit more for transplant as compared to dialysis. The future. I told her that I already gone to the blood, that I'm going to go to something else next. So at least the way we see it from here, as we mentioned before, the kidney suffers because the donor is dying. I'm talking about deceased or dying donor kidneys. The donor is dying. They are in the ICU. The blood pressure is low. They are doing the drips, and they rush them, whisk them to the OR to take the kidney out. So the kidneys suffer from that. Plus, we take the kidney, put them on a bucket with ice, and ship it back and forth, and the kidney suffers from being on the cold for too long. Then surgeons put the kidney in and open the clamp. This big rush of warm blood gets to the kidney, and that also has been shown. It's called ischemia and reperfusion injury. That results in more kidney damage. So, and that's what we call rewarming too. So, can we actually repair the organ or precondition the organ before we put it in on the recipient? We get the kidney, and can we repair them? That is the big question of the future. So this is the old way actually, I shouldn't say old way. This is the current way we do it. This is the happy surgeons. You don't see that they are happy because they have their mask and they have been operating for 24 hours straight. But that's the little kidney there on the perfusion pump. You see the pump is going, the kidney is actually flushing with the cold solution. That's why it looks a little bit pale. So they are preparing to put that kidney on the body of the recipient. And that's the way we do things now. Well, there are some smart people in the UK that came up with this idea. So, well, if the kidney suffers to be on the cold, can we rewarm the kidney on a controlled fashion and limit the amount of time the kidney stay on the ice? So they came up with this idea that actually we will perfuse the kidney with blood. So they get blood from the donor, they get the kidney from the donor, and they have this a machine that actually circulates the blood and actually oxygenates the blood. They have a membrane that pumps oxygen on the one side, and then the red cells get all the oxygen. So the kidney gets perfused with their own blood and with oxygen. So it prevents further damage from being on the cold, from being a long time without perfusion. So they get oxygen. So, and then they do that. They published their first series in UK last year, so they have done that in few patients, and they show the outcomes at least not worse. Again, this is like a proof of concept. Can we do that? Yeah, they said that we can do that in humans. So it's not done in the United States. Dr. Perez got the approval to try here in the vet school, so they're trying with sheep kidneys. Not sheep, I mean, from the lamb kidneys, the little kids, the animals. So they, on the vet school, they actually get the kidneys from the sacrificed animals, and they put it in this setup. They actually came up with a setup to oxygenate the kidney. And then, so actually we are done doing here. And I don't know if this project, I probably need to go there to project it. This is a sheep kidney that Dr. Perez did after taking, so if I can, I don't know if I can play this video here. There is a video there. Okay, so I told you that this is a sheep that had expired or been sacrificed 1 hour before they took the kidneys out. So the sheep did not have any blood pumping or anything. So after 1 hour, they went out and took the kidney out, and they put this kidney on the oxygenated. So this is truly, I mean, the kidney will literally be dead by that if you don't take out of the body of the donor in an hour. So, so actually they put there and they did and the kidneys peeing. The kidneys start peeing after being 1 hour. So it's standards. I have the video. It shows not to show what they call a heart in a box. So people that don't mind seeing the UCLA folks have a wonderful video to get a heart from human heart donors, and they put on this pumping machine, the same setup, and the heart start pumping outside of the body of the donor. So people are so excited to see the heart pumping, we get excited to see the kidney peeing. We do. So we actually not ready to do that in humans yet. Obviously, in this country, we have to go to so many regulatory regulatory agencies, but we are getting kidneys that we're discarding. So like we tried to pump the kidney, didn't pump well, we see that we won't use the kidney. We get permission to, IRB permission to put those kidneys in this perfusion pump setup. And Dr. Perez is looking at what comes out of the urine, if it is smart urine and actually doing something, or just plain urine without filtering capability. So what other thing that thing allow us, gene therapy, you cannot do it on cold preservation because they need the cells to be metabolic active to pick up the gene and metabolize and then actually incorporate the genes. So this will allow us to actually do gene therapy in the kidney outside the body of a person. So people always ask me, can we grow kidneys? And well, we are not there to grow kidneys. And even if we grow kidneys, we'll take year or 2 years to grow your own kidney, right? The kidney doesn't grow as fast. So it will take years to grow a fully formed kidneys. What I can see happen in my lifetime, my professional lifetime, I think we can modify the kidney outside of the body of the donor. So we can actually plant your own genes inside, on this kidney, on this pump. So the kidney will look like yours. So we don't need to give immunosuppression. There will not gonna be rejection. So we can actually modify the kidney outside of the body, treat the kidney rather than treating the patient, which I think will be a huge breakthrough in kidney transplantation. That is one aspect that I see the future of transplantation. So I think that is all I have it. I would take questions if anybody has it. Please. Okay.
Thank you, Dr. de Mattos. I had a question. I understand in other countries there is no waiting list.
I'm sorry?
I understand that in other countries there are no waiting lists for kidney transplantations.
In other countries? There's several things that happen. I think a live donor kidney is the best option for the recipient. So in certain countries, there is in dialysis is very expensive. I took the slides out because I don't want this to go into the bean counter type of talk. But dialysis is very expensive. Transplantation, it pays off in about a year and a half. So from that point on is cost saving for the society. We pay for dialysis, so we'd much rather pay for transplantation. So in countries like Iran, Brazil, they are heavily invested on living donor transplants. So plus they probably have people have larger families, they're less mobile, so the family lives together. So people have 5, 6, 7 cousins, so somebody will be able to donate a kidney to them. So in some countries, the Iran model, they offer, they have a mediator that if you want to buy a kidney from somebody else, the government step in and said, instead of you negotiating the rate, I want more, I'm gonna last. So the government said, no, we will be the middleman so they can have a grasp. So some people say, well, that might be a model that eventually will work in this country. So if you go beyond the, so it is a talk on itself. But if the government regulates donation, and there might be something that we can entertain in the future. That said, there is about 2.5 million hospital deaths in this country. So every year, 2.5 million Americans die in the hospital. So they're not talking hospice. So they're actually, we can assume they're viable donors, kidney donors. There's 2.5 million deaths per year. If you get 1%, just one of 100 people that die in the hospital to agree to donate a kidney, will have, and assuming that each donor has 2 kidneys, close to 2 kidneys, will have 50,000 kidneys a year. So which will wipe out the waiting list in 1 year. So actually we could do better even with the deaths that we have it. But I mean, it's interesting phenomenon. If you ask people in the supermarket and go in a drugstore, oh, if a family member is dying in ICU, would donate the kidneys? Yeah, 90% of, oh, that's a good idea, we'll do it. Yet when the when things happen and the procurement coordinator goes talking to them, 60% denial from the family. So there is an interesting phenomenon that we need more education, probably more. But yeah, eventually we like to wipe out the waiting list if we could ever come to that.
Question over here? Oh.
Sure.
Right here.
Okay.
My question is really about quality of life for your older patients that were doing the transplants. They have a few extra years of life on average, it looked like. So can you talk a little bit about length of recovery,
Yes.
increased functional ability and quality of life?
Absolutely. Yeah, I think I always tell my patient that transplant being a big surgery will set physically then back a little bit. They stay in the hospital a little bit longer. And most of the study that have been done prospectively comparing most of them comparing outcomes on dialysis patients versus people on transplant, the quality of life improve across age, even for the elderly patients in all the domains they check for quality of life. It is a long recovery because again it's a big surgery. So I failed to mention that there are some groups that are trying to experiment now with minimally invasive surgery for those patients. They start with obese patients and now they are trying to do in people that have higher surgical risk. So nowadays, yeah, we cut, there's a big incision here in the front and it is a big surgery. It takes 3.5 hours under general anesthesia. Nowadays, they're trying to do it minimally invasive laparoscopic. The incision is smaller. The surgery itself still lasts longer than the regular transplant, but I think eventually they will perfect that. They will take kidney laparoscopic. The incision on the donor, living donor, is 3 inches around the belly button, and we do all the surgeries to that, and we take a kidney from a living donor of that. So now they're trying to work a way to minimize the surgical trauma on patients. Yeah, I think as I mentioned, for the ECD kidneys, and most of, if not all those ECD kidneys are done in elderly patients. It takes about 220 days to actually recover, to have a survival benefit. So it's a little bit longer. Yeah. Yes.
How can we take care of the kidneys we've got?
I'm sorry?
How can we take care of the kidneys that we have?
So you never have to come to see me? No. Go to your doctor, exercise. People nowadays think it's the traditional risk factor: hypertension, dyslipidemia, high cholesterol, which is surprises to everybody, is a major risk factor for progression of chronic renal disease. Western diet, it's controversial. We know in rats, if we restricted their protein, and we eat way too much animal protein in our diet. That is true. Everybody agrees with that. So I guess if we were to, and actually I'm not a nutritionist, but everybody agrees that if we eat a little bit less of animal, we don't need to be a restricted vegetarian, but if you try to make a conscious effort to eat less meat, it's probably a good idea. In rats, if you get rats and restricted their protein intake dramatically, you actually increase their lifespan of their kidneys. In humans, it's a little bit more complicated. The NIH funded a study, a multi-million-dollar study, about 15 years ago. It's the what they call I'm skipping. I escaped to me the acronym for that study, but they enroll a lot of people, hundreds of thousands of patients, and randomize them to either a low protein, really low protein diet versus regular diet. And turned out in humans, they were not able to show that they prolong the time from having kidney disease to starting on dialysis. And they select people with a creatinine of 2.5. It's about 50% renal function to start with. So yes, exercise, diet, probably limiting a little bit of animal protein intake, better control of cholesterol, better control of blood pressure, strict control of blood pressure will probably help.
Thank you. I have a couple of questions. in my family, we have both dialysis and transplants. What's the expected length of life of the transplanted kidney from a cadaver as opposed to a living donor?
That's a very good question. For what is out there, and again, this is for standard criteria donor kidney. So donors younger than 60 or younger than 59, if they don't have high blood pressure, die of stroke. And so what the number is quoted, that is true. It's probably the half-life is between 7 to 11 years. So if you get a kidney from a dying younger person, 7 to 11 years. And I always tell my patients, not like it's 11 years to the day and you call me, when can you start out? That doesn't mean that. That means that if you put 100 kidneys now, 7 to 11 years from today, 50% of the kidneys are still working. And I have seen people that have kept the same kidneys for 30 years. A kidney coming from a live donor tend to last, the same statistics, anything between 13 and 16 years. So, and we think it's because of this trauma. So again, not a fair comparison. We are taking the kidneys of people that are healthy, they come to the hospital early in the morning and blood pressure is great. The surgeon take the kidney one side, they just walk with the kidney to the other room and the other surgeon suit the kidney. So there's none of this icy thing, there's none of this. So again, we won't know if we actually precondition the kidney, if we actually improve the lifespan of the kidneys from dying donors because we can mitigate those risks. If you are lucky enough to have what I call a age-related or an identical brother or sister, and because what tells us our immune system that we are who we are, it's coded on the short arm of the chromosome 6. So and we have a pair of chromosome 6. So one comes from your dad and one comes from your mom, and each one have 2. So just playing by math, you have 25% chance to actually just by chance inherit the same chromosome 6 pair of chromosome 6 from your dad and your mom to your brother and your sister. It just happen with your brother and your sisters. Doesn't happen with your kids, and because you always be half identical. So if you're lucky to have one of them, the life expectancy of those kidneys are above 25 years because the immune response is much less. You can almost see that. And if you're an identical twin, you don't need to worry about it. You do the transplant, the kidney will last forever, as long as your twin is healthy and you're. That's what I always say, be nice to your brothers and sisters. You never know.
As a follow-up, what is the average expectancy of dialysis for life on dialysis?
Well, what they say is dialysis shorten up the lifespan by 1/3. So you can go to any of those manuals, Merck manuals and stuff, and you see what the life expectancy to your age group, and then you subtract that 1/3 of that. And I obviously don't know on the top of my head, but it does reduce the lifespan by 1/3.
Thank you very much, Dr. de Mattos. That was great. Thank you. Kidney doctors always amaze me. They are truly the whiz kids of medicine.